All right, welcome everyone. Good morning. Welcome to the monthly Southside Wellness Coalition on April 20th, beginning at 10 a.m. I'm Keenan Tyner Smith, fiscal agent for the Southside Wellness Coalition. Good morning. Joining us via Zoom with our owl, so people on the Zoom should be able to see us in the room. Yay, awesome. All right, so we're going to start with the agenda first. And then introduce the folks in the room. And those of you joining us via Zoom, if you wouldn't mind in a few minutes introducing yourselves in the chat box for sake of time, so that we can have the opportunity to make sure we have plenty of time for our special presentation today. So with that being said, I'm going to roll up the agenda for this morning. And then those of you in the room, you've got a copy of the agenda, last month's minutes, as well as a leadership team meeting with you in person there. All right. All right, so our agenda for today, as you can see, is to approve the minutes here in just a minute, and then have a special presentation, our Veteran Suicide Prevention Kickoff with Allison this morning. And then we'll follow back up after that presentation with a couple of important announcements about upcoming events and trainings in the community. And so I can see people are sharing their introductions here. All right, so in the room, if we don't mind, if we could go around, introduce ourselves in the room, and then we'll do an approval of the minutes. And I'll just start over here to my right with Vanessa.
My name is Vanessa Gordon. I'm a Southside community student. I'm doing my internship with human service and substance abuse counseling. And I'm also a med tech at Piedmont Regional Jail in Farmville.
Good morning, thank you. Stephen?
Stephen Wilson, member of the Southside Wellness Coalition leadership team. Just a citizen of Mecklenburg County, and I've been in the coalition for about 5 years now.
All right, continue on.
I'm Laura. With Southstone Recovery Center. I'm the business development director there.
Awesome.
Catherine Maloney. I am on the leadership team of the coalition. I'm also with Tri-County Community Action Agency. I'm their chief financial officer, development officer.
Right. I'm Allison Byrne. I'm the suicide prevention coordinator at the Richmond, Virginia VA.
Good morning, everyone. I'm Tamika Tony. I'm one of 2 community engagement and partnership coordinators with the Richmond VA Medical Center.
Awesome. All right. So in our chat box, we have joining us Sarah Price, Members Veteran and Family Navigator for Southwest Virginia, Liam Hudson, Lean-In Project and Chairman of the Coalition, Jennifer Fitchhorn, works on several programs offering life skills training for youth and mental health first aid from VCEVT. Sheila Franklin, Senior PO in District 24 Probation and Parole in Farmville, Kimberly Throckmorton, Manager of the Center of Nursing Excellence at the Southern Virginia Higher Education Center in South Boston. Darren Adams, Divisional Adult OP Manager with Southside. Yay, go Southside, Darren. Marianne Crowder, SWC Leadership Team, as well as the Trauma Informed Care Network, TARP Leadership Team. Tricia Clayton, Leadership Team of SWC and TARP, and Shelley Clary from Virginia Poison Center. And I'll add everyone's information into the minutes for today. Fantastic. All right, so we'll go back and share last month's minutes. Check on that. And again, everyone in the room has a hard copy of that. And I'm going to put them up on the screen for folks in the Zoom. There they go. Last meeting, beginning again at 10 a.m., sharing with members present and members on the Zoom. Again, talked about the Trauma Informed Care Network outreach, SACOVA, leadership updates, the recovery run, of course, focusing on our prevention kickoff meeting, which is today. Our YADAP outreach, the Coalition Readiness and Effectiveness Assessment, which is going to be launching today, was in our agenda, as well as all of our updated trainings. And then Christy Mosley sharing information about the VCU Mobile Health and Wellness Program that's every Tuesday in Alberta. Meeting adjourned at 10:37, followed by a leadership team meeting. We need someone to motion to approve these minutes, if you don't mind, and someone to second it.
Ian, I motion to approve.
All right, thank you so much, Liam.
Second.
Steven said.
Oh, I'm sorry, thank you. Thank you, Stephen. The owl and I are like, did somebody say something? All right, awesome, awesome, awesome. All right, fantastic. All right, with that being said, so thank you for the approval of the minutes. With that being said, I'd like to introduce Allison Byrne. Again, as she mentioned, she's the Suicide Prevention Coordinator for Central Virginia's healthcare system. Her areas of professional interest include suicide prevention, historically underserved populations, and social work education. So I'm gonna let her take the floor to share with you about the Virginia SAVE training. So welcome, Allison. Thank you so much for joining us. Need to move out of your way. Take over.
Thank you, guys. Thank you all, and good morning. Again, my name is Allison Byrne. I'm a licensed clinical social worker. I've been working at the Central Virginia VA Medical Center for about 8 years or so, and in a variety of different areas, but I'm currently the suicide prevention coordinator. So I'm really grateful that you guys have welcomed Tamika and I in to talk to you today. Just want to provide you with some tools and resources that we can use to help veterans that are at increased risk for suicide, how to identify them, how to intervene with them, and how to get them connected with the services that they may need. So can everybody hear me okay on the Zoom? And of course I can't see it, but I'm assuming it's okay. Nobody's yelling, so I'm gonna keep going. All right, so before we kind of get started here today, just want to acknowledge that suicide is a really difficult topic. A lot of us have had, suicide touch our lives in some way. So if anybody needs to step out of the Zoom or in person, take a minute, definitely feel free to. And also just wanted to provide you all with immediate resources, which are non-veteran specific. So the National Suicide Prevention Lifeline, that's going to be 988. If you are working with a veteran who is at increased risk for suicide, or you're having immediate concerns about their safety, you can call 988 and then dial 1, and then that'll bring you to the Veterans Crisis Line. But it's that same basic number for both the community and for veterans. And then just any local resources, and of course you all are kind of the experts on your own area, but obviously like the community services boards and any emergency services that are local, feel free to contact them as well. All right, so in this training today, and I want it to be interactive, so feel free to, unmute yourselves if you have questions as we go through, or if you're in the room with me, obviously feel free to holler at me. But what we're going to talk about today is just, I want to give you all a little bit of a scope of the problem. So talking about veteran suicide, how big of a problem it is. And then we're going to talk about VA SAVE, and it's federal government. We love our acronyms. We'll get into what that stands for later, but basically VA SAVE is the way that we train members of our community and staff at the VA to intervene with veterans who we have concern about their risk for suicide. And then we'll talk about some resources, some veteran specific resources at the end. And then of course, if you all have any questions, we can address those as well. So just a little bit more about the objectives. Want to give you a general understanding of the scope of veteran suicide in the United States. Knowing how to identify a veteran who might be at increased suicide risk, and then knowing what to do if you do identify a veteran. So just a few facts about veteran suicide. Obviously, I think, we all of the members of the coalition are aware that suicide is an issue that affects us nationally, and it's not just one population, it's not just one, veteran, non-veteran, race, sex. It's a national issue, and there are, in general, we've seen a rising, an increase in suicide rates. And so for every death by suicide, about 135 individuals are impacted. So we're talking about family members, friends, coworkers, people that maybe you're in a community organization with. So just thinking about that ripple effect and how, one suicide can touch so many lives, I think does a really good job of putting into perspective why suicide prevention work is so important. Because we're not only hopefully having a positive impact on the people that we're assisting that might be at increased risk, but we're also, helping keep our communities healthy, our workplaces healthy, our families. So just one way to think about it that I think kind of puts it into perspective. Thank you. So suicide it's pretty rare in our work. So what we do on the suicide prevention team at the VA, Tamika and I are two of the members there. I'm the suicide prevention coordinator. And so part of our role is to identify veterans that are at increased risk for suicide. And we're able to put what we call like a high risk flag. So essentially a veteran will be followed more closely by our team, provided with case management services, wraparound care for a period of at least 90 days. And then at the end of the 90 days, we reevaluate, determine if, we think that continuing the flag is going to be helpful for the veteran, or, maybe they're feeling better, maybe their symptoms have decreased, or their risk factors have, been mitigated by some of the protective factors. And so we're able to kind of end that flag. But when we work with veterans clinically, it's really, really rare that we're going to say, oh, well, this veteran is at increased risk for suicide, or maybe had a suicide attempt because of like this one thing, right? It's usually not one event. It's really complex, and we'll talk a little bit about risk and protective factors, but those can be at all levels. So individual, community, and societal. When we're talking about risk factors, they're characteristics that are associated with an increased likelihood of suicidal behaviors. So just because there are risk factors present doesn't mean that, yes, this person is definitely, at increased risk for suicidal behaviors, but there's a correlation. It's not necessarily a causation. Protective factors, like risk factors, they can kind of help mitigate or offset those risk factors. So we'll get into examples, but a risk factor might be having a diagnosis of PTSD, but a protective factor might be being engaged in outpatient treatment, coming to their appointments, taking medication as prescribed. So those kind of things, not that they cancel each other out, but it's sort of a one for one, if you will. When we're talking about those veteran suicide and preventing veteran suicide, we really work to maximize protective factors and then minimizing those risk factors at all levels, and helping kind of bolster those risk factors where we're able to. And sometimes that comes in the form of like clinical interventions, getting them connected with mental health services, sometimes getting them engaged with community, or providing education to family members. So just looking at all the different risk factors at all levels, and trying to bolster protective factors to offset those.
I'll let somebody in and point her.
Sorry.
No, you're fine. This little blue box. No worries. I'm your support team right here.
Thank you.
Just making sure that, okay. All right. Okay, good.
Okay. All right, so here's a list of some of the risk and protective factors that we see that are pretty common. So it is a risk factor to have a history of prior suicide attempts or suicidal behavior. And like we talked about before, just because you've had a prior attempt or prior preparatory behavior doesn't necessarily mean that, somebody will die by suicide, but it is a risk factor that we look for. Mental health issues, different diagnoses and different manifestations of symptoms, those can be a risk factor, especially when those symptoms are interfering in the veteran's ability to, function in their day-to-day life. Substance abuse is a risk factor, access to lethal means, and we'll talk a little bit more about what lethal means later. Having recent losses, so this can be job losses, relationship losses, losses of housing, right? And then they can also be, death in the family, legal or financial challenges, unemployment, homelessness. These are a lot of the risk factors that we see when we are working with veterans. As far as the protective factors, having access to mental health care is a protective factor, feeling a sense of connectedness and self-worth, feeling like what you're doing matters on some level, having good problem-solving skills, and that includes help-seeking skills. So being able to recognize when they're not feeling so well, or when the coping skills that they've been using are no longer working. Having a sense of spirituality for a lot of veterans can be a protective factor, especially if there's a faith community involved that they feel engaged in and accepted in. Having a mission or purpose, having physical health, having good physical health, or even like being able to engage in improvement of physical health. A lot of the veterans that we work with have chronic physical health conditions. And so, if you're in chronic pain, maybe you get sent to acupuncture, and maybe the chronic pain isn't all the way gone, but it's getting better. That can really be a protective factor. Being employed, and with the caveat that, your employment is able to allow you to meet your basic needs. And social and emotional well-being, just overall, those are some risk and protective factors. And again, our goal is just to minimize the risk factors, boost the protective factors. Does anybody else have anything that they might include on here that we didn't? This is definitely not an exhaustive list, but anybody think of anything might be risk or protective that you all have seen or can think of? No, okay, that's okay. I will keep going. Oh, go ahead.
Oh, I was just gonna say, I work in housing, and people's access to safe, stable, affordable, consistent housing has been a huge determinant of their mental health that I've seen.
Yeah, that is definitely a big one. And right, like you're saying, it's not only the quality of your health, safe, all, yeah, those can all have a little bit of your feelings, right. Right. The DA, but
Can you hear us now? Can you hear me now? Better. I'll try to be a little louder. Is this better? Yeah, we're shouting. Can you hear? Oh,
Okay,
that's good.
okay. All
Okay,
right.
then you on.
Sorry to everybody in the room.
All right, there you go. All right, we're raising the volume here. All right, we'll go with it.
Thank you. Okay, so, we talked about some general risk factors and protective factors. Those are gonna be more applicable to everybody. But now I wanted to talk a little bit about some veteran-specific risks. So, one of the things that we see, having frequent deployments, especially when there's not a whole lot of like government in between them. And it could be a combat deployment, it could be a non-combat deployment. That's one of the veteran-specific risks that we see, or, that might make somebody at increased risk for suicidal behavior. Exposure to extreme stress, and that can be workplace stress, like there are a lot of veterans that may work in corrections or firefighters, after they separate from the military, that can count. Again, having stress payments, physical or sexual assault while in the service, or military sexual trauma, and that can put somebody any length of deployment. So we do see some of those longer deployments, the adjustment back might be more difficult, and so that can be different. And then having service-related injuries, especially those injuries that might have effects on police functioning, that's also a risk factor, that might put somebody in. I wanted to say too, one of the things that's happening here, but we see a lot of veterans that maybe had different MOSs, and sometimes we see like veterans that so they would be the people that maybe they weren't in kind of the combat zone, but they yeah. So basically what your job was in the military. So, some people, and I can't. But, some people worked in maybe communications, some people worked in, did art. So it's just what your job is. And I cannot. Yeah. Yeah, we actually see that a decent amount, and that is something that comes up, and a lot of times the vets are the people that are acknowledging, hey, I've had these symptoms for however many years, and a lot of times what we see is that maybe when they retire or when their kids are grown up, or the family structure is a little bit different, and they have time to maybe think about some of the things that might have happened past traumatic event, that can be the symptoms. A lot of times that is the case with the VA, specifically with men. And they're not always suicidal, but PTSD is in veterans in those. And you're right, it's 60s, 70s, 80s, wasn't really understood. different modalities when together. And I think culturally too. We really want a bigger medical center. PTSD clinic, we have specific modalities for military sexual trauma as well. We have a pretty robust mental health clinic in general, so they do group treatment, individual treatments. We've got psychiatrists, pharmacists that work with the mental health medications. Sure. No, you're good. Uh-huh. Mm-hmm. Yeah, definitely. Uh-huh. Yeah, and we actually have a program called BJO. It's the Veterans Justice Outreach Coordinator. Or that's the person that runs the BJO program. So they work with veterans courts that are local. So if they catch the veteran like before they've gotten sentenced, they can work with the veteran sometimes to get them into veterans court if the local area has a veterans docket. And a lot of times those work a lot like drug court. So it's a judge that is aware of a lot of, common veteran issues and how mental health and substance abuse can exacerbate maybe some of the risk factors for being engaged with the criminal justice system. Mm-hmm. Yeah, yeah. Huh? I know different things. Yeah. Once they come into the system, leave the system. Mm-hmm. Yeah, they are, and so that BJO coordinator can help them transition once they're like getting out of the correctional facility as well. So they can help them with just case management of getting them connected back to primary care, to, to mental health, whatever their needs might be at that point. Yeah, Veterans Justice Outreach. Mm-hmm. And I can send that. Share. Any other questions right now? Can you guys still hear me okay?
They haven't said anything, so.
Yeah. I'm
Keep your microphones up, we're talking loud.
I'm going with no news is good news. Okay. You can now. Cool.
That's good to hear.
Okay. Oh.
Here, good.
Okay. All right, so I'm gonna hit you guys with a few statistics. And so every year, the National Office of Mental Health and Suicide Prevention, they do a big annual report and they look at the trends related to veteran suicide. So this was released in, I think, November of 22, but the last full year that we have data on is in 2020. So I'm just gonna share a few data points with you guys from that, just to give you a scope of how big the problem is, right? So we're talking about veteran suicide deaths. This chart shows from the beginning of when they, started doing the national in 2001 up to 2020. So you'll see that in 2020, 6,146 veterans died by suicide. And per day that worked out to about 17 veterans dying by suicide a day. That was in the year 2020 in the US. And you'll see that number actually went down from 2018 and 2019. So 2020 is one of the lowest years that we've had since 2001, which is good news, but obviously 17 veterans per day, when you think back to that 135 people per suicide death, that's a lot. And so obviously we want that number to be zero. So we try to use this data to inform the way that we're intervening, maybe in areas that we're missing, like what are we not catching, or what areas do we maybe need to outreach to, right? Like community agencies, and that's a big part of Tamika's role, because we only see, you know, we're able to identify the veterans that come through our doors. There are a lot of veterans that never have any contact with the VA, don't want to have any contact with the VA, and that is totally fine. They receive their care in the community, but it's really hard to, you know, kind of catch them and be able to provide them services if we're not aware, because they're not receiving their health care through us. So that's why doing trainings like this for community members, coalitions, partnerships are so important. And again, just thank you guys for having me.
Transpired in 2006, 2007, that looked at that spike.
It is. It is.
Stayed up.
Yep. Yeah, yeah.
That, what is your belief and cause of this? Is there like administration going through a revamp where people weren't getting the kind of care they were used to getting? I mean, do you guys know what went on?
I feel like that's short answer, no, right? Like it would be difficult for me to point to, this is one thing, this is another thing. I could share with you maybe a theory, and it doesn't so much have to do with maybe the years that you mentioned, but when we're looking at maybe like 2014-ish, there was they were trying to get people out of the military, right? And one of the things that we know from our research is that transition period from when you're active duty to when you are, you know, trying to transition back into civilian life, that can be really difficult. That can be like a risky period, even for somebody who's maybe doesn't have a lot of other risk factors on paper. Yeah, so that's my theory, but as far as like, I'm not sure exactly what happened in those years. I'm sorry.
No, that's all right. I think that would be very valuable to know.
Yeah, absolutely.
Do you have any preliminary figures for anything after 2020? Because I'm just wondering if COVID spiked those numbers when people had to be in isolation.
So actually, we saw that the numbers went down in COVID, and I think that there's a slide that's going to talk about that a little bit more, but I can send you guys a link to, like, the whole data report is online, so I'm happy to send you guys a link to that, you know, once we.
Curiosity.
Yeah, no, and it's like, they break the data down a lot of different ways, but like you were saying, I don't know that there's necessarily a whole lot of, this is a causation that we can definitely come to about why those numbers spiked, if that makes sense, which is, I mean, it makes it difficult because, like we talked about before, suicide is multifactorial. And so it's so hard to put your finger on it and say, hey, this is, you know, you can say this is probably a factor, but it does make it difficult. And things vary so much locally too, because one VA is different from another VA. We all have suicide prevention programs. We all have suicide prevention coordinators, but the way that work is carried out might vary a little bit depending on your location. Sure.
I think I agree with him. I think the numbers are higher because, and the reason why I say they are higher, because when they come into incarcerated, and a lot of are at home, you know, because some of them are disabled.
Yeah.
Some have isolated themselves. They couldn't move around.
Right.
Family couldn't come to see them.
Yeah.
And a lot of them has mentioned that they have thought about suicide because there's no physical contact.
Right.
You know, they lost friends, family, you know, during that period of time.
Yeah.
I think the numbers are high.
I would.
Just by what I have heard.
Yeah.
And seen.
Yeah. And I think when we talk about like suicidal ideation, I would definitely agree with you there. I think probably more people thought about suicide. This graph is only measuring reported veteran suicide deaths in each year. And so that, and you know, our data, to be frank with you, we only know that a veteran has died by suicide if the coroner is reporting that to us, right? Or family members reporting that to us.
And that might be another
Mhm.
issue there where it became more acceptable to say that somebody.
Right,
died by
right.
suicide At some point in time too, where I do know somebody who died by suicide and it was totally.
Yeah.
Passed over.
Yeah.
back in the, you know,
But a lot of those numbers is not, being counted for.
Mhm.
Just like your people who's in the nursing home and your veterans.
Absolutely.
A lot of those numbers not being counted, so
Yeah.
I'm pretty sure it's way higher.
Mhm.
Than you think it is.
Yeah, yeah, and it might be. I mean, we can only kind of go off of what, you know, what we know and what we have confirmed, but you're right. And there are a lot of veterans who maybe don't even identify themselves as veterans. Like maybe they serve for a couple of years, but they didn't serve in wartime. So they're eligible for VA services, but they might not identify themselves as a veteran. And so then, you know, how does that, there are a lot of places where that mechanism for reporting can be kind of messed up. Mhm.
Question, when there is a suicide, are these numbers derived solely from suicides by people who were dealing with the VA?
No, no.
That's coming just from coroner's report.
Yeah.
And they know the person was a veteran.
Mm-hmm,
Okay.
coroner, or if a family member calls, a lot of times that's how we get notified. Sometimes if there's a community provider and they know, like a mental health provider or a medical provider, and they know that the
But they don't
veteran
have
is.
to be dealing with the VA.
Exactly. Mhm.
Thank
Yeah, no problem. All right.
I'll move the little box.
Oh, sorry.
Maybe that little box over for you.
Thank you.
So it doesn't cover over the.
you.
Just to have access to
I know, I know. I would be lost. Um,
I'll take that compliment. I'm learning.
so your question about whether or not these were just reported suicide deaths, you know, among veterans that had contact with the VA, this pie graph shows, we're talking about the veterans that died by suicide per day in 2020. So when you break that down, you can kind of see in the light blue, are the veterans that didn't have any contact with the VHA, which is like the VA medical side, or the VBA, which is the benefit side.
It's equal.
Yeah, that's what
Yeah,
I'm not
yeah.
seeing the difference between
Oh,
contact
wow.
with the VA or no contact.
Mm-hmm.
That's interesting.
Yeah, yeah. Yeah, it's equal, it's exactly equal for that last year. And so then, you know, of course, there are other pie slices for if they had any contact with just the benefit side of the year, that's gonna be, or in the year prior to their death, that's gonna be the yellow. The gray is gonna be within the last 5 years, if they've had any medical VA contact. And then the red is gonna be if they've had any medical contact within the last 5 years. So the red is if they've actually seen somebody at a VA medical center, and the gray is if they have been enrolled, but they haven't had any appointments at the VA in the last 5 years.
I don't know what to draw from that.
Yeah, so
It might, well, yeah. Meaning the care that they're getting outside is equal to the kind of care they're getting inside the VA. You could possibly extrapolate that, but
it could
private care,
be.
no.
Yeah, I mean, it could be,
No.
but it's hard, again, I think it's hard to make a lot of causation, you know, inferences just from this data, but I do think that it's important to know how big the problem is. And so that is really, you know, the function of the numbers, because I think that people kind of generally know, okay, yes, veteran suicide is a problem, but I think seeing the numbers really can give you a sense of how large those, how large it is and how much work we do have to do. Yeah, so 2020, when you break it down, about 17 veterans died by suicide each day. Among those veterans, about 7 had a VA encounter in 2019 or 2020, while 10 had not. And so when we're staying on the topic of the numbers, obviously those numbers look bad, right? There's a lot to do. The numbers can be overwhelming when you're thinking about 6,100 veterans, died from suicide last year. But these anchors of hope just are a couple of positive points that we were able to take away from the data. So 343 veterans died from suicide in 2020, then in 2019. The number of veteran suicide decreased in 2019 and then again in 2020, which had the lowest number of veteran suicides since 2006. And then age-adjusted suicide rates in 2020 were the lowest since 2016 for veteran men and the lowest since 2013 for veteran women. And when we're talking about 2018 through 2020, the adjusted rates for veterans fell by 9.7% as compared to a 5.5 decline for non-veteran US adults. And when we're talking about like the term adjusted, it's because you have to adjust with the general population and cut out everybody that's like under 18. So you're kind of comparing apples to apples more. And then this was the point about the pandemic, despite the onset of the COVID pandemic. In 2020, age and sex adjusted suicide rates among veterans fell 4.8% from 2019 to 2020, and it was a 3.6% decline among non-veteran US adults. So that
you're seeing a larger decrease versus general population.
exactly. Mm-hmm.
If you don't mind hitting that blue button up there.
Sure. So one of the things that we talk about a lot when we talk about suicide prevention is the idea of lethal means safety. So lethal means that is essentially going to be anything that somebody could use to end their life. A firearm, a medication, a knife, sometimes a car, right? Like anything that you could use to end your life. When we talk about suicide prevention, we talk a lot about how to just help with maybe limiting access to lethal means, depending on, how acute the suicidality is. What we want to do is just do something that will build in barriers to create more time and space between the impulse to end one's life and the ability to get access to that lethal means. Because when you're in that moment, and we'll talk about that in a little bit, the suicidal crisis, the data shows that the time in between when somebody first has that thought and when they actually act on that thought is really not very long. So anything that we are able to do to pre-plan, because we're talking about safety planning, so generally we're not doing that when the veterans is actually in the moment of crisis, but anything that we can do to make it a little bit harder to get access to those lethal means when you're having that thought can really go a long way to helping keep veterans safe. And this isn't just for veterans, this is, for everybody when we're talking about lethal means safety. But it's a collaborative process. So it's very veteran centric. It doesn't look like, we're going to take your guns generally. It's something that you talk about with the veteran, and you have to, be respectful of their values and also things that they may need. They may need to take their blood pressure medications because that is, something that they need to do for their physical health. But maybe we could talk about putting it in a lockbox, or maybe the doctor could help with prescribing them, maybe 1 week at a time, so that there's not as much on hand for them to, use that to end their life. So it's gonna look different. The safety planning and lethal means safety portion of things is gonna look different depending on who you're working with and that veteran's particular circumstance. But we'll talk a little bit about some of the numbers when we talk about suicide deaths and methods of suicide. So this chart is kind of busy, but what it really is comparing is non-veteran adults, and then it breaks it down into men and women versus veteran men and women, and methods of suicide. So you'll see firearms, poisoning, suffocation, and then everything else is kind of othered into the last category. But when we talk about firearms, suicide deaths in 2020, about 72.1% of male veterans, that's how they died by suicide, was via firearm. And then 48.2% of female veteran suicides were by firearms. When you compare that to the non-veteran side, for non-veteran men, it was about 55.3% of deaths were by suicide, and then non-veteran women about a third, so 33.3% were by firearms. So we see, there's a big difference there, like 20 percentage points or so.
Is I guess, overdoses and poisoning, is that in that line?
Yeah, that would be an overdose, yes. Anybody have any ideas as to why, maybe some factors that you think help explain why the death by firearm rate is so much higher in veterans than in the non-veteran population?
Trying to use it.
Yep, yeah. Training, access, that comfort with using them, all of that. Yeah, so when we talk at the VA, a lot of times when we're in practice doing safety planning with veterans, a lot of our safety planning does, it does revolve around firearms. Also, oh, sorry.
Suffocation.
Yeah. We have gun locks that we're able to provide veterans, and those are actually in the back too. We're gonna leave you guys with some. They're like the corded kind, so they've got a key. We also talk about, hey, could you maybe give your firearm to somebody else to hold for a while until you're feeling better, or could you even keep your firearm locked away and maybe keep it locked from the ammo, not having it loaded, right? Anything that we can do to build another step that they would need to use. Yeah. And then with the medications, we also are able to provide medication lock boxes for veterans. And then we can coordinate with their medical providers too about maybe dispensing the medications on a more frequent basis. So those are some of the ways that we talk about lethal means safety that are most common.
And of course, as a coalition, we already participate in Lock and Talk Virginia. So
Awesome.
we're prepared. We have, in addition, we have the locking medication boxes,
Cool.
large and small boxes, and we are also moving to order the pouches.
Oh,
And once
okay.
we get the zip pouches,
Yeah,
and
yeah.
figured out how to brand them,
Mhm.
then we'll be launching those as well.
That's
So
great.
We're excited that, so we've already got some of the work done as we do this outreach.
That's awesome. You guys are like already lethal means safety experts. That's great. That's wonderful. Yeah, so going back to talking about the suicidal crisis, and that's gonna be from the time where the veteran or the person first has the idea to end their life to when they actually take the action to do that, like begin engaging in the behavior. So they did a study of people that had attempted suicide. This is back in 2001, and they asked them about, hey, how long did it take from the time that you first had the idea, on that date to when you actually attempted. And they said within for about 71% of the responders to that survey, they said that the entire process took less than an hour. So, and then of those, a good portion of those took less than 20 minutes, like almost half took less than 20 minutes. So when we're thinking about that suicidal crisis, it's often not that long, relatively speaking. And we know that suicide can be an impulsive act. And so if the lethal means is right there, then obviously it's gonna be a lot easier to follow through with that. And so just kind of goes to show why lethal means safety is so important and why that's so important to address in your safety planning with the veteran. And then the next graph just shows fatality rates for different methods. So firearm injuries, there's about an 85 to 90% fatality rate when firearms are used in a suicide attempt. And then when we look at all the other methods combined, so that would be poisoning, suffocating, etc., the fatality rate is about 5% there. So just showing that, you know, with that, the lethal means, firearms are definitely the most lethal means. And so that's why, that's one of the things that we really try to focus on and make sure that people have, you know, safe storage options, or just kind of talking through what a lethal means safety plan might look like for the individual veteran. So lethal means safety, I know I've talked it to death, but reducing the access to those lethal suicide methods, it's one of the few population level interventions, so from like a public health model that's been shown to decrease suicide rates. When people survive a suicide attempt, about 90% of those people that survive one suicide attempt do not later go on to die by suicide. So we know that just because having survived a suicide attempt or having previous suicidal behavior is a risk factor, that doesn't necessarily mean that that person is going to die by suicide. If we can collaborate with them ahead of time to help them survive that suicidal crisis, then we've likely done a lot to prevent suicide, dying by suicide for the rest of their lives. So suicide is preventable. Do you guys have any more questions about that data, or, and I can send out the link to the study too. Somebody in the chat. Thanks, Mary. All right, so now we're going to talk about VA Save, which is our community-based intervention to teach people in the community how to help veterans at risk for suicide. So we love our acronyms with the federal government. So the S is for signs of suicidal thinking, should be recognized. A is for asking the most important question of all. V is for validating the veteran's experience, and then E is encouraging treatment and expediting getting help for the veteran. And we'll talk about those individual steps. So the signs of suicidal thinking, we have some here. Feeling hopeless is a big one that we see a lot. Feeling like the walls are closing in, there's no way out of the situation. Sometimes we see veterans exhibit big changes in mood or affect. So having increased anxiety, maybe feeling agitated, difficulty sleeping, sometimes sleeping all the time, or mood swings. Feeling like there's nothing keeping them going, there's no reason or motivation to live, having rage or anger, engaging in risky activities, including substance use, but it can also look like driving erratically or spending a lot, or you know, maybe sexual decisions that they wouldn't have made if they were feeling better. Withdrawing from friends and family. Sometimes we also see maybe giving things away to friends and family. And then the the kind of real red flag signs that we see are, if a veteran expresses that they're thinking about hurting or killing themselves, if they're looking for ways to die, sometimes that can look like Googling different suicide methods or, trying to access lethal means if maybe they didn't have access to them in their environment now, talking about death, dying, or suicide. Sometimes that can be writing notes too, or the self-destructive or risk-taking behavior, especially involving alcohol, drugs, and weapons together, because we know that, substance use can lower your inhibitions, therefore it makes it more likely that you might engage in that impulsive behavior, that suicidal, the either prep behavior or attempt. Are there other signs that maybe you guys have seen in your work that you think might fit here? I can go back to this one too. Okay, well, we can keep trucking then. So A is for asking the question. So the most important question of all, are you having thoughts of suicide? Are you thinking about ending your life? Are you having thoughts of killing yourself? How many people would say that they have experience asking that question, either in their personal life or professional life? Yeah. Looks like a lot. Okay. Okay. Any feelings about that, or like, how does it feel to ask that? How has it felt in the past? Maybe how does it feel now? Has it changed for you, how that's felt?
Well, I can comment that, and first coming into this job 5 years ago, 5 years in June, that I had limited experience, I didn't have any training, even as a public school teacher, any training in suicide prevention. So initially knew how important it was for me to have that conversation and learn how to have that conversation.
Yeah.
And then becoming a trainer in suicide prevention for the agency. And knowing what the stigma was, but 5 years later, after having had conversations in my personal life, many times with folks around me, I feel like at this point that I've lowered the stigma in my family. And I've lowered it. You said 135 people. I was thinking in my head, like from the other avenue, like how much stigma could you then reduce in other people around you? It's like doing a tally in my head. Of like how many folks now will approach me with that topic. And then I also want to share with you all, since I'm not, the brightest brick anywhere, that if I can reach the point where I'm like vastly comfortable with this conversation and can help other folks approach me, that I really feel like if we were really intentional about feeling like I need to be approachable and talk about suicide prevention, that's really a skill that you can have under your belt in a matter of, months and days, to feel comfortable walking up to folks and saying, I'm concerned about what I hear you saying or doing. Are you thinking about killing yourself? Right. But I can tell you as a trainer, is even recently having taught a suicide prevention training, it's a very difficult spot for people to reach. And so I constantly want to just say, look at me as a sample of that. Like you can do it, you can reach that point where you can be very comfortable and people can sense that from you. So I think that's part of the hope, I think, with if people really take to heart what you're presenting today and begin to intentionally using it, that they will start rippling their effect out on everyone around them. That's been my experience.
I think that's an awesome point, and I appreciate you sharing that perspective, because it is like can feel very uncomfortable. And I think Liam said in the chat, it can feel off-putting if there isn't an established rapport. which I think is true too. And one of the things I do in my role is sometimes there's not necessarily as much time to establish that rapport. Sometimes you do have to kind of jump in and do, you know, kind of do the preliminary assessment, ask the question. But I take your point too. It's important to make people feel comfortable when you're really able to exhibit that. Basically, you're kind of putting off to them, I can handle it if the answer is yes. So like, don't feel afraid to, you know, to answer honestly. And I think too, like Liam said, a lot of people feel relieved to be able to share their thoughts with somebody and receive that support without judgment, and to have a little bit of hope. And we'll go into that, kind of goes into the next step too. But one of our jobs, I think, when we are assessing for suicidality, when we're trying to intervene and get more information, is to provide encouragement, instill that hope that, hey, I see you, I hear you, I'm validating your experiences. I can see why things would be hard for you right now, but here's, you know, and it might not be quickly, but here are some resources, here are some things that we can do, here's what I can connect you to. I think that can really go a long way. When we go back to that hopelessness that we see in a lot of the veterans that are considering suicide or have suicidal behaviors or attempts, even just being able to like establish a little ray of hope can really, really go a long way into helping them remain safe. So thank you guys for sharing. I appreciate that. So just a couple of tips about asking the question. Definitely ask it if you've identified warning signs or symptoms, if you're having concerns about the veteran's safety, and try to, when you're able to, and I know it's different in different settings, but if you're able to ask it in a natural flow of conversation, it's usually going to go a little bit better than if you're, you know, they're walking in the door and you're saying, hey, do you want to kill yourself? But one of the things to not do is to not ask the question like, oh, you don't really want to kill yourself, do you? You're not suicidal, are you? Because that you're conveying that you essentially are kind of like leading them to a no answer, right? And then not waiting to ask the question when somebody's halfway out the door, because if the answer is yes, you want to be able to ask follow-up questions and kind of dig into maybe some of what's behind that. The other thing I try to caution people away from is asking, do you want to hurt yourself? Because that's a different question than, do you want to end your life? Do you want to kill yourself? Plenty of veterans would say, no, I don't want to hurt myself. I want to kill myself. I want to be dead. So just making sure that you're asking it in the right way to elicit the information that you're trying to get. So we're on to B, so validating the veteran's experience, which we talked a little bit about. Talking openly about suicide, being willing to listen, being non-judgmental, right? Trying to break that stigma down that has been there for so long. And I think especially has been there with a lot of military or veteran populations. I've talked to many veterans who part of their hesitation with engaging with mental health, even if the symptoms were longstanding, were, well, when I was active duty, I didn't want them to take my firearm away. I didn't want to lose the trust of the people that I was serving with. I didn't want them to think that I was, you know, crazy or anything like that. And so even just by asking the question and asking it in an empathetic way, we can really go a long way toward breaking down the stigma. And just recognizing that the situation is serious, and then reassuring the veteran that that help is available. And then we talk about encouraging treatment and expediting getting help. So if somebody is acutely suicidal and you have concerns about their safety, like in the here and now, it's really important to be able to share that information. And of course, that might look different depending on where you're talking to the veteran, where you've identified the veteran. Not leaving them alone is you know, it's gonna be a big priority. Trying to get somebody to seek immediate help, and some of this was written for inside the medical center, so it might look different if you guys are seeing the, you know, veterans in the community. But, you can always call 988, and 988 is also, they're 24/7, so they're a really good resource for people to be able to reach somebody, you know, anytime that they need to. If the veteran has a weapon or some kind of lethal means, you know, on their person, you can always call 911 as well, or the local emergency numbers. But really, we just want to reassure them that help is available. And then, of course, the local emergency rooms too, those are generally open all of the time. And so if you're having acute safety concerns, you can get the veteran to the local emergency room where they can do, you know, an emergent psych eval and kind of go from there as far as treatment goes. Do you guys have any protocols in place, like currently with, you know, somebody's expressing suicidality in your different work areas, what to do? No.
I'm retired.
Yeah, yeah. You can write your own, I guess.
Yeah, you know, having been through a lot of the trainings that we do here,
Mhm.
yes, I feel comfortable, but, you know, in my personal experience with it is that it's not uncommon. I don't go a year without losing somebody
Mhm.
for these reasons. So I was asking questions before I knew what I was doing. Because, and that's born out of, your feeling of self-worth. You're always asking afterwards, well, what could I have said or done,
Right,
you know?
right.
Or did I, you know, through a lot of training since then, I'm much more comfortable, and I realize that I'm not the one who needs to be the counselor.
Mhm.
You know, I think
Yeah.
that's a lot of people's fear.
Yeah,
If I
yeah.
ask this question and you say yes,
Mhm.
what
What do I
say
do then? Yeah.
You know,
Yeah.
I'm not a counselor.
Uh-huh.
I don't feel that way. I don't know what to,
Mhm.
you know, but in learning that it's not on me, it is on me to follow through
Right,
and make sure that I get that person to the right people.
right,
At
right.
that point, I have to trust in the process.
Yeah,
So,
yeah.
I work with, a lot of people with severe substance misuse issues. I
Mhm.
think that's not my job. That's what I do.
Mhm.
Because I used to have that problem.
Okay. Yeah.
And that's where I run into that.
Right.
Not a year goes by in the last couple decades where
Mhm.
I haven't watched this happen at least once a year.
Yeah,
Uh,
yeah.
And you get comfortable really quick when somebody's brand new walking in the doors and you start talking to them, feeling out around those issues.
Mhm. Mhm.
Because, it's either gonna happen around then or it's gonna happen around the time somebody relapses.
Right.
So.
Okay. Yeah, yeah. Yeah, and I think you're right, you know, starting from a place of, I don't really know what I'm doing, and maybe I have some trepidation around this. And because what do I do?
If they say yes.
Yeah, yeah, exactly, exactly.
Put me on the spot, man.
Right. And I think I mean, honestly, I think that prevents a lot of people from asking that, even in a hospital setting. I think especially like non-mental health related fields, we see it all the time. And one of our roles in the hospital is to help different areas with writing SOPs. So, okay, if a person has a positive, we use something called the Columbia screen. It's like a 9-item questionnaire about suicidality in the last 30 days. Who takes over then? Because we know we have a different screen that we need to do. So, but who's the identified person in your area that's going to do it? And if you're working in places that don't have sort of a protocol in place, I think it's also a really effective suicide prevention intervention to maybe, you know, ask leadership about it or work on maybe developing one, or if there's one that doesn't work, changing it. How can we improve it? Because it is something that I think that's a big barrier for people, and sometimes like that's kind of talked around. People don't want to say it, but that fear is real. And I ask people all the time, but there's still like an adrenaline component too that comes in with it. And because you feel very responsible, like you said, for not necessarily for being their therapist or like curing them, but for getting them those resources and making sure that they're locked in and that follow-up is gonna happen. I think there's a comment in the chat. Liam said, we do have individual safety plans and use trauma-informed conversations to guide appropriately, like whether hospitalization is appropriate or if it can be managed with other resources. And he said, good point, not everyone can be the counselor. All right. So, just some general tips for when you're talking with veterans at risk for suicide or really any community members. Remaining calm, listening more than you speak, maintaining eye contact, trying to exude confidence, even if, you know, maybe inside like the butterflies are going on a little bit. Not arguing and using open body language, limiting questions and letting the veteran do the talking. Sometimes you have to ask some initial questions to kind of get them talking, but you know, if they are talking, trying to keep the questions to a minimum generally, and use supporting, encouraging comments and being honest and being upfront, letting the veteran know that there aren't generally any quick solutions, but that help is available and that you want to play a role in getting them that help. All right, any questions about, oops, let's skip one. Any questions about the SAVE process before I go under resources? All right, well, so we already touched on the Veterans Crisis Line. Again, that phone number is 988, dial 1, and it's not just for veterans. You can call about a veteran. So if you're a friend or a family member or a member of the community, you know somebody is a veteran, you can always dial that number on their behalf. And they're 24/7. Here's a little bit about some of the work that they've done since they were founded in 2007. So they're available, like I said, all the time, through text, through online chat, through phone call. So they really are super critical part of our work on suicide prevention. And so when veterans call in that are in our catchment area, so even if they're not affiliated with the VA, if they're in the Richmond catchment area, say they call, you know, tonight, then tomorrow morning, myself or another member of the suicide prevention team, if they are amenable to it and that's what they want to do, we would give them a call back and just assess their needs. And sometimes they're not calling because they're suicidal. It could be they're calling because they're lonely and they want resources in their community about how to you know, make connections with others. It could be medical concerns. It could be a variety of things, but we work really closely with the Veterans Crisis Line, and they're super helpful, and I think they've done a lot of great work in a relatively short amount of time because they've only been around since 2007. Like I said, every VA medical center is going to have a SPC or suicide prevention coordinator. Some of them have several depending on the size of the medical center. So if you are ever needing to figure out, hey, this veteran goes to this clinic, who's the suicide prevention contact? I need some resources. You can go to this website and locate the suicide prevention coordinator. Yeah.
Just quick, I just want everyone to know that we'll make sure that they.
Yeah.
Keenan has a copy too, and she will share this.
Because these links are embedded. Yeah.
Everyone has this information.
Yep. Thank you, Tamika. And then here, the Veterans Crisis Line also has its own resource locator on their website. So if a veteran is wanting to know about their Veterans Benefits Administration, how their claim is going for disability, if there's an outpatient clinic, you can find all of that information on the VCL resource locator. And so we have Reach Out, which is a campaign that is just generally for veterans to encourage them to address mental health concerns, that there are resources available. So you'll see these. You'll see, in September, you'll see kind of more of the reach out. There's a website, but the website is mostly videos with veterans kind of telling their own stories. And so a lot of times veteran to veteran is the best way to that the veterans that we work with like to connect. Sometimes somebody who may have been through something similar, seeing them tell their story, they can help instill that hope, right? Something was going on with me. I was able to connect to these resources. Sometimes, just having an example can help instill that hope in some of our veterans. So that is, reach out. They have a bunch of different resources that are tailored specifically to veterans that might be, struggling with, mental health concerns. Make the Connection is pretty similar. So again, more videos, more kind of chats that they can have with people that are peers. They're telling stories about their recovery from different mental health and substance abuse challenges.
And those are different campaigns that you're talking about?
Yeah.
Okay.
Keep it secure. So when we're talking about lethal means safety and gun locks and, helping with medication lock boxes, they have a lot of resources if maybe you're trying to plan around lethal means safety. So they're a great resource. And then there's also the National Shooting Sports Foundation. They also have their own resources that speak specifically about firearm safety, when it comes to lethal means. And then here's the VA resource about, reducing improving firearm safety. And then I'm talking about different things that you might not consider as lethal means, right? Like cleaning products, different household things that maybe you're always going to have in the house, right? Like you're always going to have a butcher block. But talking about how we can maybe put a few more barriers in between accessing the knives or the bleach at the time that the veteran's having a suicidal crisis. We have a variety of apps, mobile apps, so they're available on, iOS or Android. And they help veterans address a lot of mental health challenges sort of in real time. So that picture shows like the whole app suite. And these are all, done by the VA, but I wanted to focus specifically on the PTSD Coach app. So it gives you an example of our safety plan. So this is a model of the safety plan that we use in suicide prevention and throughout the VA. So what it really focuses on like our warning signs. So signs for the veteran that they might be about to have a suicidal crisis. They might be about to, think about ending their life, triggers for them, warning signs that they should use their plan essentially. The second step is coping skills. So things that they can do alone, things ideally that they could do anywhere. What are some of the things that have helped them calm down or kill time in the past? Social distraction. So people that they can call, and those aren't necessarily going to be the people that they are going to call and tell every feeling and thought to. They're going to be more like the people that can always make you laugh, or the people that can maybe talk your ear off, and that's going to buy you some time. And then step 4 are family and friends that you would tell, hey, I'm having concerns about my safety, I'm having these thoughts, that you would trust them to intervene appropriately if you were to reach out to them in that manner. Professionals you can call, so a lot of times that'll be therapists, psychiatrists, crisis line, any local mental health resources, or even sometimes medical doctors. And then things that you can do to keep yourself safe. So the last step talks about risk mitigation and lethal means safety in the home. So this safety plan usually we give to people on paper, but in the PTSD Coach app, they can have it with them all the time, which is really nice. So they don't have to, keep it in one spot or carry it around. Coaching into Care is a program for families or loved ones, friends that are trying to support a veteran that maybe they feel like would benefit from seeking support, but the veteran is not, you know, they're not there yet, they don't want to do it. So it really can provide resources for friends, family members, loved ones about how they can best support veterans in their day-to-day life when maybe they're struggling with a mental health concern or even like a physical health concern, how they can best kind of understand some of the veterans' challenges and the ways that they can best provide support to them. The suicide risk management consultation program is actually a really great resource that's available to VA staff and non-VA providers. So it covers a variety of topics, but basically if you want a consultation about a veteran who you think might be at increased risk of suicide, but you're not sure if it's intermediate risk or high acute risk and you want to talk about it, or you want to do some legal means safety planning, but maybe it's a means that you haven't dealt with in your past practice before. If you're having difficulty with documentation or how to engage high-risk veterans, you can email them at that srmconsult@va.gov, and they'll set a time for you to talk with somebody whose entire job it is to help consult with other clinical providers who are serving veterans around suicide prevention. So it's a really, really cool resource. And again, you don't have to be affiliated with the VA at all to access that. So they also provide post-vention resources. So when we go back to talking about those 135 people that are affected by every suicide death, that is going to have that ripple effect that we talked about. Post-vention helps the people that are left and are mourning the loss of the veteran. That includes friends, family, community members, sometimes providers. It can be really difficult for medical and mental health providers too after a loss. People in the workplace. So there are resources, including podcasts, information, films. It can also link you to local resources. And then lastly, if you ever wanted probably a shorter version of this training, and you wanted to share it with somebody in your agency or anything like that, you can always download it from Psych Armor Institute at the link, and it's available for free. And then any questions? No,
Thank you.
no, thank you guys. Thank you guys. I'm sorry I ran a little long, but I really appreciate your time and your invitation. And if you do have any questions, I'm gonna email this out, and so you guys feel free to email me or call me if you need to follow up about anything. Yeah.
Oh, and I was gonna say, just, to the coalition members as well, if you guys ever feel in your own, other respective agencies, or if you're members of social clubs, and you feel that they, folks that could benefit from this training as well, please let us know. Because we come out in the community, Allison and I, and, we go to all different types, businesses, social clubs. We definitely provide the training as well.
All right.
We
Thank you
appreciate that.
guys.
That was not too long.
Okay, good.
That's right. And I see you guys brought some items. I was just wondering, like, I know I do have, we have like a cachet of, the veteran cards that have the 1-800 number on there. I see you guys brought us some stuff that says 988. We would definitely be interested in getting some more of those items. I know currently in our lock and talk boxes, we have the veteran card that don't have 988, which is, we know that number still works. So we're still continuing to pass those out, but I'll follow up a conversation with you guys, how we can get more possible.
Yes, and we can definitely do that. We are kind of in the process of trying to get 988 as well.
Okay.
Right, we get that stuff from the national office and they're kind of rolling it out. Yeah.
Okay.
With the more they're coming in with the 988 on here, I will definitely provide that to the board.
Okay. Awesome. Other questions? Oh, might have a question in the chat box. Let's check. Let's see there.
Forgot all
Stop
about it.
here.
I'm
sorry.
Let me go back so I can yell.
No, you're fine. I was just looking to see what they were saying. Gotta hop off. Liam said thank you all. Jennifer said thank you for the presentation. Thank you so much. All right.
Okay.
All right, folks, well, then we'll wind down. I know your time is valuable and we appreciate very much this presentation this morning. And let me say, and when I put together the minutes for the meeting, remember that all the information that we share at every coalition meeting goes on to the Be Well Southside Coalition website, and there you can go. Will be for every meeting. We put the minutes, the recorded session, and then any uploads for documents. And as you guys, leadership team does, and anyone else can do, if you don't see it, let me know, because I work with Ellen from Foxglove. You know, she is the one responsible for maintaining and making sure everything is and all the frosting is on that website. So once we go back forth with those, I'll send those to her, and then she'll put them on the website for people to download. And just so y'all know, last time I was on the website, my gosh, how the resource cachet that we're developing on bewellsouthside.org, it's like, I'm impressed myself just looking at how fantastic all the good work we've done. So that will be on there. Once the minutes are ready, we'll get everything uploaded. Like I did last meeting, I am getting in the good habit of sending out directly to those who attend a coalition meeting. Like today, the items that you share with me, but after that, they'll just go up on the website so that anybody can access them. All right, so just a couple more things. Be mindful that the Trauma Informed Care Network is having their in-person, and I'm going to be blasting it, for lack of a better word, today out through the coalition. It's in the newspaper. I saw it in the Mecklenburg Sun. Well, it was Wednesday's papers, but I saw it this morning, which is Thursday. Sorry, my week's been busy. There's already ads going out for the on May 4th, Thursday night at the Colonial Theater. There is going to be a showing of the movie Resilience. And that's not okay. I'm gonna bring that up in just a second. But let me share with you. Let me jump to just one more item. Launching this afternoon, you're going to receive an email. I want everybody to look at this. And that is the required, every 2 years, we're required to launch our Coalition Readiness and Effectiveness Assessment through Omni. So starting this afternoon, you will receive a personal email from Mackenzie or myself asking you to click the link to choose Southside CSB, choose Southside Wellness Coalition, answer questions about the coalition. They're all questions where it's the scale of 1 to 5, right? I agree, I disagree. There's some short answer questions. And then if you will screenshot your confirmation, submit it on this link. See, we're getting all fancy, as Stephen said, I'm getting pretty good with this technology. You'll click on that website, you'll upload your screenshot, and then we're going to send you a gift card right to your email that you'll be able to use. I'm working with a local company to help us do that. So that's coming out. That is if you are a member, you're a supporter. We're creating a targeted list. So if you haven't yet gone on our website and joined as a member, today would be a good day to do that, so that we send that out, we'll have you captured and we can send you the evaluation. This is not a public launch. This is only for folks who have attended coalition members, joined the coalition, or related to the coalition in some way in the last 2 years. It will be a targeted approach. So if you don't get the email from me and you feel I've made a mistake, please let me know. Again, we're incentivizing this participation. Omni wants to know how well our coalition is doing, which is a good thing. All right, and then one more item, and I know we need to adjourn soon. We've had lots of good information today, and that is, give me just a second. It wasn't in my folder. Is the flyer that is in the newspaper about come on, where's my flyer in the newspaper that disappeared on me there. Okay, that is Sarah, if I can find it. Now I'm challenging myself here, aren't I, Stephen? Can I find it? Oh, no, is that on the Zoom? No, it's not, that's right. Hang on, where's the ad? We just put the ad in the newspaper for the Tick-In meeting. And I lost it a second ago, where is it? It crashed on me, hold on. I mean, I don't wanna do the attachment, I just put it down, hang on. I know I'm holding you guys. April 14th. Anyway, while I'm talking it through, so on May 4th, Tuesday night at the Colonial, the newspaper ad just went in. That we are the Tick-In Trauma Awareness and Resiliency Partners are having their event. Oh, there we go. Yes, there it is. All right. Go back to the Zoom. Y'all gotta love this, right? There it is. Woo-hoo! All right, there we go. So see here, guys, so in the newspaper, in all 3 county newspapers, the Trauma Awareness and Resiliency Partners presents a community screening and conversation of the movie Resilience, which we bought licensing agreement for to share to the public. So it wasn't like a movie we picked up. It shipped to me like it came from the $5 bin at Walmart, but it's not the $5 bin at Walmart. We have a licensing agreement. We're going to be showcasing it. So on Thursday, May 4th, as you can see by the flyer that's in the newspaper, fancy a registration link, put your phone to it. I checked this Mecklenburg Sun this morning. It worked. God bless it, it worked. It kicks to our website. People are registering. We're capturing just their county they're coming from. We might get some people from outside the area as well. It's an RSVP that's coming back to me. We're hoping to get 100 folks or more to show up at the Colonial Theater, 5:30. The address is available. 5:30 coming in. We're going to be doing walk around hors d'oeuvres with conversations and table setups for folks. And then about 6 o'clock, this will be determined by the TARP leadership team. About 6 o'clock, we're going to usher people into the downstairs area of the Colonial and watch the movie. And then after the hour of the movie, then bringing the leadership team of the Trauma Informed Care Network on stage with microphones to do a Q&A of how people can become involved in the Trauma Informed Care Network. And the Colonial's been really supportive and invite us through their doors. They have their volunteer, that theater is basically run by a group of wonderful volunteers. They're coming in to help us. So as many folks that want to come and help us, because I've said, well, if you're bringing 5, 10, 15 volunteers, we will bring 5, 10, 15 volunteers, help set up to have the event. So everybody put that on your calendar. Thursday night at the Colonial. I will probably arrive there by 2 or 3 o'clock. If you can come and help set up, do tables, get everybody ready. It's a no cost event, and they're also free of cost. The Colonial is going to put it on their marquee starting at the end of next week to roll the announcement to the public. And we've notified the local police department that we're having an event. So any questions about that? Super, super exciting event happening. And then also back to the agenda, was there a Sakova update?
The meeting was canceled. They originally moved it, but they moved it to Easter Monday, and when they realized nobody was coming, they canceled it. It's been rescheduled for, we're just gonna have next month's meeting, and that's it.
All right, awesome. And then the ADAP conference, we are still advertising to support a team of youth and adults to the ADAP. The deadline is June 1st. We don't currently have an application, so if you know of anybody that would like to attend that. In-person trainings, I just talked about the Colonial event. We also still have open seats in the youth mental health first aid. That's all virtual on June 6th. We still have open seats in the Revive training. We've got, one coming up this Friday, then on May 18th and June 13th, and then every month thereafter, there's always gonna be a virtual Revive for the community. And virtual ACEs, there's one today, actually, at 12 o'clock. That's 3 hours, and then, of course, with the state team, there's 2 additional ones. And then finally, leadership team updates in the room, in a hard copy. And online, it's not there. The leadership team met on March 29th, and they're also going to be meeting, their next meeting is going to be on May 1st. Did anyone want to share anything from leadership team minutes? I'll put them out. They did some team building. They talked about the community needs assessment. Liam is serving on the Southside Planning District Committee. And so we are submitting a letter of support for the opioid abatement authority grant that they're applying for that begins May 5th. And so we'll talk more about that as a leadership team as well. That's an exciting opportunity for us to partner, with that.
And
outreach.
potentially get additional funding for some help assisting with them. Is that a piece of that? Or do we-
Yeah, yes, part of that as well is we're gonna be putting in some requests for, yes, what we could do as a coalition with some of that funding. Absolutely,
Yes.
absolutely. So we are, Liam, he's not here anymore, but he is definitely on the table with that, and I'm working with him to come up with some documents, letters of support with our letterhead, moving that forward and submitting that to the planning district before the deadline, which is in 2 weeks. So super exciting opportunity that I think that he's gonna lead us into being a part of that. All right. All right, well, that with being said, I'm gonna stop the meeting. There we go. All right, let's stop recording.